It is my pleasure to introduce now our Connelly lecture speaker, Dr. Anil Parwani, who is joining us from the Ohio State University, where he serves as the Donald Sennheiser Chair of the Department of Pathology and also the Chief of Pathology Services for the health system. His research is focused on diagnostic and prognostic markers in bladder, prostate, and renal cell carcinoma. Dr. Parwani also has expertise in not only in surgical pathology, but also in pathology informatics, including biobanking, whole slide imaging, digital imaging, telepathology, image analysis, artificial intelligence, and lab automation. Dr. Parwani has authored over 400 peer-reviewed articles in major scientific journals and several books and book chapters. Dr. Parwani is also the editor-in-chief of Diagnostic Pathology and co-editor of the Journal of Pathology Informatics. So please join me in welcoming Dr. Parwani. Thank you.
So this is an exciting part of our program, and it will not be complete without the Connelly lecture. The Connelly lecture series, as we know, is designed to acknowledge the work of Dr. Donald Connelly and his colleagues who got us to this point. So we have Dr. Parwani here, who is going to talk to us about the role of AI in digital pathology. And I think we need to understand, how did we get this far? How did we get here? We lost Dr. Connelly last year, and we are honored to have his widow and two of his grandchildren, Jonathan and Chris. Thank you for being with us. It's a great honor. It just shows that the apple doesn't fall far from the tree. So Jonathan and Chris are pursuing academic career just like their grandfather. The Donald Connelly Lecture, as I said, is meant to honor Dr. Connelly's work. From 1975 forward, Dr. Connelly was the professor in laboratory medicine and pathology at the University of Minnesota Medical School, the director of Health Informatics Division, co-director of AML training informatics, and so on and so on. He took on several leadership positions in our organization, as I said, and his work got us to where we are today. He developed the first successful University of Minnesota laboratory information system in the Department of Laboratory Medicine, with dedicated staff and developers who used their own computers and their own network back at the time to develop this software. He lectured in several institutions, several venues, and put together a program for our residents and the residents from Mayo Clinic to work together on informatics. We are so honored to be part of his legacy, and his legacy is summarized in the 50 years of history that I will give to Dr. Parwani at the end of his presentation. The lectureship has been made possible with the support and financial support and endorsement of two of our distinguished faculty, Dr. Mike Lujet, who is a PhD in social psychology, and he worked in our department. He worked a lot on residence teaching, informatics, and developed several projects, and has been very instrumental to our education mission, and we benefited all from him, especially me, with his psychotherapy sessions he offered me in my office privately. Took advantage of him. I needed that sometimes. His wife, Wendy Lujet, is the former dean for libraries for the University of Minnesota, and with their support, we are honored to have the lectureship series. And the plaque for the lectureship For those of you who like to go to the 7th floor, it's hanging there and has names of distinguished speakers who participated so far, and your name is right there. Without more delay, I'm so honored to present to you Dr. Anil Parwani.
Thank you so much. It's a great honor to be here and present the Anil Connelly lecture. I'm grateful to be in this legacy that Dr. Connelly created. So I come from Columbus, Ohio, and this is the game that I'm going to go tomorrow at noon. So I booked a 5 a.m. ticket to go back and watch the game. And my wife is picking me from the airport, and we're going to be there. And I'm glad to be here at the University of Minnesota and be part of this amazing legacy that Dr. Connelly has created here and be part of this workshop. Dr. Connelly is clearly a leader and pioneer in health informatics. I started my career in Association of Pathology Informatics and in Pittsburgh, and Dr. Connelly was a great part of it and has clearly built tools which we continue to use today and have continued to grow. And I'm going to show you examples of this. But one of the first things that comes to my mind is the clinician's workstation. So if you're a pathologist, you interact with your lab information system and the EMR. Some of that early groundwork was done by Dr. Connelly, and they actually created the foundation for this work. So what I want to discuss today with you is digital pathology and AI, and talk about the diagnostic gaps, talk about how we can use these tools for improving quality in our diagnostic processes. I want to show you some applications which are here today, and I want to show you a glimpse into the future where we might be going. So, how many residents in the room? Are you using digital pathology? Somewhat, yeah? How many pathologists who are using digital slides today? Several of you, yeah. I mean, the presentation from Dr. Pari was all about digital, so excellent talk. So as a pathologist and as a resident, do you think we have more work or less work today? More work, less pay. So I think there are opportunities today for a digital disruption. So I love my microscope. I'm on service today. I'm signing out today. How did I do it? Because I was at the airport at 4 a.m. and I was reviewing my cases. I ordered stains. And this afternoon, I got some of the stains back. I didn't sign out the cases yet. I'll go back tomorrow after the football game and sign them out. But I've already emailed the clinicians, and some of them were lymphoma patients, and I've already consulted HemePath. So this is the power of using a digital workflow. So there are many challenges in pathology today. Overworked pathologists. We don't have enough medical students going into pathology from the United States. We have about 650 residency slots, and about 40% of those are not filled by the US medical graduate students. There was a survey done where we asked medical students, why are you not choosing pathology? They view pathology as an invisible specialty. You know, the stereotype of a pathologist is someone who's in the basement and working with dusty slides, but that's not really true, right? I'm sure it's not true. And when I was walking into this building, I was trying to figure out what is the shape of this building, but that's not necessarily true, right? So we have challenges in pathology. There is subjectivity in our diagnosis. We have a shortage of pathologists. We have fewer medical students going into pathology. There are some parts of the world where there is only one pathologist for 1 million people. So think about those odds. So, but why are we excited about pathology informatics? Why are we excited about digital pathology? All these are creating pipelines of data. If you think about what Dr. Connelly in his earlier works showed us, was a way to integrate information. So we truly are in a knowledge age of precision pathology. We as pathologists are clinicians. We are part of the clinical decision-making process. And these tools can help us with improvement of our quality of our diagnosis and reduce errors. So why do we care about this, right? So if I look at issues in pathology today, lack of standardization. We don't even have a common barcode on glass slides across all the institutes. There is a lot of subjectivity. There is a lot of manual processes. There is a shortage of pathologists worldwide. Pathologists, if I did a survey of pathologists and pathology residents, burnout rate is continuing to increase. And there is an explosion of medical knowledge. So as a resident, I learned about 5 kidney tumors. Guess what? We have about 80 different kidney tumors today. How do we learn all this new knowledge, tackle all this work that's coming on in your way, and be able to make a good diagnosis? And this is why I think there are tools which can help us today. So I think when you think about what Dr. Connelly envisioned, creating a personal digital assistant, right? So this is something which was thought about in 2007, and we are talking about this in 2024. So think about that. This was someone who was a visionary, who thought about this, who clearly built tools for pathologists in 2007, which are still relevant today. So I want you to keep this perspective as we continue this talk. So today we have digital pathology and AI, and I'm not saying, I love my microscope. I'm a GU pathologist. I'm on service quite often, even though I use AI, I still love my microscope. And I still use my microscope. At OSU, we have whole mounts. So I still use my microscope for that. But I want to take you today to a journey from a glass slide to a digital image, which is composed of millions of pixels, to a diagnosis and possible therapeutics achieved coming from that. So pathologists do many manual tasks today, many complex manual tasks. We count cells, we assess grade. A simple case of breast carcinoma, it's not really simple because the grade is composed of counting mitoses, looking at the size of nuclei, looking at the size of tubules, and see how much of this is tubule formation. So AI can help us with some of these tasks today. So again, going back to what I showed you, what are the challenges, possibly we can have more standardization, we can have more objectivity, we can have more automation, and more accuracy and faster diagnosis. So as a pathologist, you have more time to do other things, and you can keep up with the knowledge. So So I'm going to focus on whole slide imaging, which is the process of converting a glass slide to a digital image using whole slide imaging as a technology. So why today? What is good about today? Why didn't we do this 20 years ago? Why didn't we do this 10 years ago? I think the answer is that today the current environment is more suited for deep digital pathology and AI models. What do we need for AI models to work? We need high computing, we need supercomputing, we need really powerful computing. It is possible to do that today. At Ohio State, we have a supercomputing center. I'm sure in Minnesota, at Minneapolis, you have similar powerful computing centers. We are building better algorithms, which are very, very relatable to everyday sign-out. And we have more data than ever before. So as pathologists and radiologists, we are contributing an immense amount of data into the electronic medical record. So we also have a lot of milestones, right? We have the first FDA-approved algorithm to diagnose prostate cancer. Think about that, right? Where did we start? We started with data. This data was used to train algorithms. This algorithm is now being used to make a diagnosis of prostate cancer. And prostate cancer was, the grading of prostate cancer started here, right here in Minneapolis. Dr. Gleason, in 1966, designed the Gleason grading system. And it's the most, in my opinion, it's the most powerful oncology tool today. You know, if you can, even if you don't have AI, it still is the most powerful oncology tool. And as a prostate pathologist, I use it every day. But it's also easy to create algorithms around it because it's so well documented. The follow-up data is so well documented. So overall, when you think about digital pathology, we've come from in the 1960s, where we started to use images to consult each other, to the point where we have completely integrated digital pathology workflows. So where are we today with whole slide imaging, where we can convert a glass slide to a digital image? We have scanners which you can load up to 1,000 slides, and you can scan them in under 1 minute. So we've come a long way from the early scanners, which would take about 90 minutes to scan one slide. We have a variety of scanners out there which are used for routine surgical pathology work today, cytopathology, hematopathology, and other areas of pathology. So when I went to one of my first pathology informatics meeting, I predicted in 2004 that we are going to be completely digital by 2007. Clearly, I wasn't thinking like Dr. Connelly. I was very optimistic. But today I can say safely that we don't have to think about, are these images of diagnostic quality? Several of these vendors have been approved for primary diagnosis by the FDA. So as a GU pathologist, when I want to look at this prostate cancer, I want to look inside the nuclei, and I want to be able to see two nucleoli, and I want to be able to separate them easily. So we have this diagnostic quality today. We are using them. So any ideas which city are we in? It's in the Midwest. Columbus, yeah. Somebody said Minneapolis. So again, it's a reminder for me for tomorrow. Make sure I get up in time at 3 a.m. and be on the flight. So I'm going to share with you what have we done at Ohio State University. We started in 2016, and our goal was to archive all our cancer cases going back 10 years. But we also wanted to sustain this program. So we also wanted to use this for primary diagnosis. It was early because the first scanners that were approved by the FDA came out in 2017. So we started using this, and in 2018 we were signing out digitally. In 2019 we moved to Epic, and we started using Beaker as a LIS. We started scanning slides for primary diagnosis. And during COVID, everyone wanted to use digital images. Everybody wanted to sign out digitally. There were pathologists who didn't want to come to the hospital. So during COVID, we saw a 25% uptake in our adoption. Today, we are almost 95% of our pathologists are completely digital, and surgical pathologists. Hematopathologists are not signing out digitally yet, and cytopathologists are not. So this is our histology lab, and we moved into this space in 2019, and then COVID happened. And then we started to see these pathologist workstations pop up. So today we have pathologists who are signing out digitally, and I keep telling them, you need to come back to the hospital, because if you don't, I'm going to give up your offices. I'm going to give them away to the oncologist and the radiologist. So one of the things that we're trying to do is minimize slide travel time. So our histology lab is 3 miles away from the main campus. All the blocks are processed there, slides are generated, and images are created. From embedding, cutting, H&E staining to digital pathology, it's a space that we designed based on a lean process. So slides are being prepared continuously, and they're being scanned, and they're being delivered for delivery, but before they are delivered, pathologists already have an image. So this is the workstation for a pathologist, where they can see, whenever there is an eye icon, they can click on it and see the slide, and they are instantaneously available. It doesn't matter which order they were scanned in, they're available for pathologists to review. What I feel is there is more objectivity in clinical measurements and annotations, and it really helps us to collaborate. So this is during COVID, where pathologists were signing out digitally with the residents. But this continues even today, where we have dermatopathologists who are 10 miles away, and they are signing out with residents who are at the main campus. We also cover community hospitals. Our pathologists travel there, and we have the same collaborations enabled. So the system is enabling clinical collaborations more easily. Multiple people can be on the system. So all of you could be logging into the system and collaborating with each other during tumor boards and other things. My favorite part is this, where I can click on a button and I can see who's online, and I can call them or don't even have to call them. I can just click on their button and make them join my chat. So I don't know if this is a good thing or a bad thing. I don't know. It's like sometimes I feel like, when you can you can just set settings on your phone where you said, I'm not available. But this system we have configured so nobody can do that. They're always available. So if you're a pathologist in Minneapolis, you could be always online 24/7. Or at Ohio State. So this is where we are today. We have 4.27 million slides scanned, almost 460,000 cases scanned. And you can see, starting from 2019, we got a big bump during COVID. We continue to have digital slides being used, and the pathologists are continuously engaged. So I have implemented technologies in my career in Pittsburgh and other places. And change management is not easy, especially for pathologists. I have noticed that we got a big bump because of COVID, but today we have several pathologists who are signing out digitally, and if the system goes down, which it does rarely, pathologists get angry and they send angry emails. They don't want to go back to the microscope because the glass slides, literally if you come to my mail room where the pathologist mailboxes are, you will see piles of glass slides which are sent for filing in rubber bands which have never been opened. So I want to actually now move to the point where we don't deliver glass slides. But what if we have one or two cases where things are out of focus? So we still continue to do that. So we are able to now review cases. We cover several community hospitals. We are able to review cases from our colleagues who are 90 minutes away in real time. We are able to do frozens remotely. We are able to do FNAs assessment remotely. The scan slides are instantaneously available. So this is just an example of a smear in cytology for adequacy assessment. So residents like it, but I don't know if that's a good thing or a bad thing, right? If you are a resident who has never used a microscope, do you think, residents in the back, do you think you will be able to get a job somewhere in private practice? So we still use microscopes in some specialties like hemopath and cytology, but I don't know how long we can sustain that. So personally for me, digital slides, I like that because I have a direct interface to LIS. Just like Dr. Connelly had imagined of a virtual workstation, we can do that today. We can share cases with consultants, clinicians. We can flag cases. We don't send out controlled glass slides anymore. We can do this in real time. We can flag cases easily. So people always ask me, is digital pathology going to slow you down? How many of you think if you are going to sign out digitally, does it slow you down? Who thinks it makes you faster? Why do you think that?
100%. We tried it in Toronto. In Toronto, we moved to completely digital. And when you see, some field, it depends on the subspecialty. I'm a gynecologic pathologist. Gynecologic pathology is very low power pattern. So the more you depend on the low power, the more you depend on the pattern, it gets you very fast.
Yeah, I agree. What I like about it is the previous cases are available to you because they are tagged to the cases. All right, so next quiz for you. You ready? Which city is this? Pittsburgh. No, it's not Pittsburgh. It's a Midwestern city. It's a Cleveland, yes, exactly. You're looking at the flats in Cleveland. I was supposed to be in a wedding. One of my fellows is getting married in Cleveland today. And I'm here today, but I sent apologies to her, but the wedding was close to this area. So we talked about digital pathology, we talked about glass slides being digitized. Let's talk about what can you not do with glass slides. So just as a discussion, are there things that in the audience that we can imagine that you cannot do with glass slides? What else can we do when the glass slide is digitized? So give me one or two things. So let's say that you have this complex case that Dr. Pari was showing. It's digitized now. What else can we do with that digital image? Share it easily.
You can have multiple people looking at it at the same time.
Yeah, exactly.
Not necessarily in the same room.
Exactly. Yep. Sharing images, collaborating, and you can use image analysis, you can use AI. So everybody in this room is thinking about digitization, they're thinking about what could we do next, right? So if I talk to pathologists all over the world, they come to a point where they've gone beyond a glass slide to a digital image, but they're not going further than that. So that's, if you think about products that you are being manufactured, there is a chasm, and everybody has a chasm in their journey. The residents have their chasm, attendings have their chasm. So you have to think about what is your chasm. How do you go from this cliff to the next cliff? So what a glass slide, going beyond the glass slide, you think about what else can we do? And that's the exciting part of digital pathology and AI. We can identify things, we can quantify things, we can synthesize this information, we can create new knowledge and predict things about a cancer or a disease. So the next few minutes, I want to show you specific examples of AI that we are using at our institute, but I also want to give you a glimpse into the future. So with AI, we can do more pattern recognition, we can do image analysis, we can, when we were trained as residents, we learned how to diagnose diseases and cancer, identify plasma cells, identify neutrophils, eosinophils. These all can be translated into pattern detection and feature detection. So I'm going to show you examples of AI algorithms that are already ready for prime time, where they use the basic machine learning process of detecting things, classifying things, segmenting, quantifying, and localization. So quantitative digital image analysis is here. It's being used, and actually there's a separate billing code for it, 88361. We can use it, you can get paid more. How many of you are in private practice? A couple of people, but if you're in the university, it may not come directly to your paycheck, but if you use it, the university will get the revenue. So quantifications of biomarkers. So if I asked everyone in the room, within 5 seconds, you have to tell me how many blue dots are here. Exactly. Everyone will have a different answer. And I can guarantee everybody, every pathologist in the United States will have a different answer. But I can press a button. Within 28 seconds, I can analyze a 2 millimeter square area for a gastric neuroendocrine tumor and get the same answer. The answer will be the same in Minneapolis and across the bridge, or in Cleveland or in Columbus. What about count? So there is more objectivity which could be created with using these algorithms and using image analysis. What about lymph node mats, right? Who loves to screen lymph nodes? You don't like it? It's actually very easy. You can push the glass and... So we have started to try using algorithms for this. So we use a image management system, and these are the apps that are available to pathologists. They can choose the MET detection app, and the computer will find the metastatic cancer for you. So before you even come to work, you can have your cases screened and find the metastatic positive nodes, which will be on top of the stack. And it's not just lot of cancer. Like you might say, I don't need a computer to help me with this. I can find the cancer here. I'm a pathologist. But what if you had this small focus of isolated tumor cells? Everybody confident that on a Friday evening, you're ready to go to work, go home? You will not miss this? Possibly you could miss it, right? So what about if I told you that I can actually predict what cancer type this is, right? So not only can you identify metastatic cancer, but you can classify it. Will that be helpful? Right? Today we do, I had a case today where I had a tumor which I thought was renal cell carcinoma. It didn't stain with any of the markers. So before coming to this talk, I've ordered more immunostains. You can send it for molecular screening, but look at this classification where the lymph node has been classified by AI to be colorectal with a 99.9% confidence. So it's possible to build these tools and make them available for pathologists. What about for making a diagnosis and grading cancer, screening for cancer? So like I said, a lot of work has been done in prostate cancer, breast cancer, and colon cancer, and gastric cancer, but other tumors are being there. So you can use AI for pre-sign out. So before you come to work, you can have a screening tool for you. Which can pre-order your IHCs for you. It can also, during sign out, help you as creating a report template, creating a second review for you. Or after sign out, it can check your work. If you miss cancer, it can check your work for you. So this is an example of a prostate cancer tool which is FDA approved. And you can buy it today, you can load it, you can start using it. Which can grade cancer, quantitate cancer, and even look for perineural invasion and things like that. So this is an example of a prostate biopsy where there is perineural invasion and cancer. And you can see the red areas which is where the cancer is. And this information is not only being pre-screened, but it can also be entered into your report. What about breast cancer? This is an example of invasive lobular carcinoma. And if I use the algorithm, it can highlight the areas of cancer. What I love about it is it can also do the mitosis for you. It can also assess for tubule formation. It can also assess for nuclear size. So what about mitoses? Who likes to count mitoses? So this is an example of an AI tool that I recently implemented in my research lab, where the computer is identifying mitotic figures for you. And you as a pathologist, soft tissue pathologist, are just drinking your Starbucks coffee and looking at the screen and just doing a check.
Don't say this, our boss is sitting there.
People always ask me, does this mean we need less pathologists? And I said, no, you need more pathologists. So at the end, as a pathologist, you will see the red areas, which are definite mitotic figures. Orange is something you should check, and yellow is low probability. Same thing for clinical pathology, right? So we can even do this in smears. We can do this in bone marrow aspirates. We recently implemented a gram staining or automated gram staining AI tool in microbiology. So it's not just anatomical pathology. AI is touching all areas of pathology. Who likes to look for AFB? And how many of you actually are accurate? I went to one of my first GI sign out, And the attending asked me, is there H. pylori? And I said, no. And the first high power view she looked at, there were H. pylori, lots of them. So I said, I don't know why I'm in pathology. But many years later, I'm glad I'm in pathology. So these are tools for H. pylori detection without doing immunostains. But I want to share something interesting with you. So we did a study where we actually looked at pathologist immunostaining behavior for H. pylori on a digital screen versus a microscope. We found that pathologists were ordering more immunostains on a monitor versus a microscope. So, and this is without AI. They were just looking at a gastric biopsy, but they were ordering more immunostains. So clearly, there still is areas of improvement in resolution and so on. All right, so we started from thinking about data, thinking about pathology informatics. We have clearly diagnostic quality images today. 10 years ago, when I used to go to meetings, people used to ask me which scanner to buy. Are these images diagnostic quality? We have clearly demonstrated that by multiple studies that we can generate diagnostic quality images. Maybe not the entire spectrum of pathology, but for the most part, greater than 95%. So what's coming next? So I want you to think about virtual staining, synthetic data, 3D pathology, and integrated large language models. So once the glass slide is digitized, we create millions of pixels. We are able to render diagnosis on it. As pathologists, we can use AI to help us do some of those tasks, but we can now go beyond that towards prognosis and predictions, right? So pathologists are always asked from researchers to look at this H&E image and segment it. How much necrosis is there? How much adipose tissue is there? How much trauma is there? We have algorithms today which are very accurate in doing all of this. This is also important for treatment assessment. If the patient got chemotherapy, how much of this was chemotherapy related? But what are the exciting things coming in pathology today? So if you look at the left-hand side here, so if you look at this area here, these are histologically stained H&E images. They came from the histology lab. Here you have virtually stained H&E images. So if I switch the labels, will you be able to reliably tell me that which one has been histologically stained, which one of them has been computationally stained? Right, so this is an area which is starting to emerge. So any GU pathologists in the room? So here you have two images side by side. Can you tell me which one is H&E in the lab, which one is generated by the computer, and which one has intraductal carcinoma? They're identical, right? Exactly. So these images here are generated in the histology lab. These images are generated in the computational lab. These immunostains were generated in the histology lab and immunolab. These images were generated by the computer. Can you tell them apart? And it's interesting because this is intraductal carcinoma, where you have basal cell staining. So what I'm trying to tell you is that pathology is progressing and we are moving towards generative AI. What about 3D pathology? So radiology and pathology are starting to converge. There's a school of thought out there that pathology and radiology are not unique disciplines anymore. It's all a continuum. It's all diagnostic medicine. In fact, if you go to Dell School of Medicine in Austin, Texas, they have a program now in diagnostic medicine. So residents can go in there, be part of the diagnostic medicine residency program. They can then, after initial training, they can go into pathology or radiology. And this will start to become more and more, available to medical students. So if you look at this images here, this is cancer, this is benign. With 3D imaging, we can take a core and spatially see where the cancer is. And we can use AI to use deep learning to find where the cancer is. So again, this is not ready for prime time yet, but there are clinical devices now that are being tested by the FDA. So we are in the world of ChatGPT, right? So who uses ChatGPT? Every day, right? You can use ChatGPT to do an evaluation on my talk also. You can just say, use ChatGPT. But these are all chatbots. So imagine a world where, so think about the significance of this. So everybody uses Netflix, right? So on my flight today, I was watching a movie on Netflix. It took 3.5 years for Netflix to get 1 million users. Facebook, 300 days. ChatGPT, 5 days. So what if we can build a ChatGPT for pathology? So when you come to work, you can talk to your ChatGPT robot, have a conversation with them. It's possible to do that, right? So how do you make your diagnosis, right? We have consensus meetings, we have difficult cases, we ask each other, we try to get to a consensus. And even with consensus, we're not really at consensus. We do this every day, right? We look for, when I was a resident, I didn't know what the answer was, and it's 7:50, the attending is going to come at 8 a.m., I better know what this is, or I need to scribble something down. I looked at books, I searched for similar images, I looked at high power, and I made a prediction. And if I was a senior resident, I was probably more accurate. But this is what your scanning and labeling and such could look like today, where you have an image of an unknown tumor, a sarcoma, which is rare, and you feed it into the computer, and it's a query image. In this case, it's a subependymoma. The computer finds the best image for you and searches and finds the best image for you. What if you could do this while you were signing out? What if I have an app for you? Just like an app on your smartphone, right? And I click on this app and start chatting with it. What is this? I don't know what this is. What stains can you recommend? If I was an academic pathologist at the University of Minnesota, all my colleagues were near me, I could just walk to somebody, show them this case, take the glass slide. But what if I was in South Dakota and I was by myself? I didn't have anyone. What if I was in Tokyo? I was still working for OSU, but I was in Tokyo. I would love to have this tool, right? So I would start chatting with it. I will ask it, what is this? And the computer would say, these are your suggested diagnoses. These are your recommended IHCs. Look at these papers, read about this. Residents, would you not love this tool? And you would have an AI assistant, just like Dr. Connelly predicted in 2007. So, as we think about AI, it's very task-oriented. AI is typically it's a single algorithm per task. For breast cancer diagnosis and grading and staging, we need 3 different algorithms. So all the things that I showed you today, they are very task-oriented, quantifying biomarkers, PD-L1, finding metastatic cancer in lymph nodes, counting mitosis, grading cancer, finding H. pylori. These are very task-oriented. Real intelligence, in my opinion, comes with all of you who are, it's experience-based, it's knowledge-based. You're integrating multiple types of data, and it's also context-based. So when I first started my first job as a pathologist in Pittsburgh, I was assigned to sign out with residents, and we didn't have digital slides at the time. I took my glass slides, we sat around a multi-headed scope, and I looked at the slides, and I picked up the first slide. Oh, this is prostate cancer. And I looked very confident in front of the residents, but inside I was sweating. I went back to my office. I called my wife, I'm going to be here for 12 hours. I had maybe 30 cases. I looked at every slide 3 times. And then I issued a diagnosis. And after 1 month, I got better. It became 8 hours. It became 4 hours. And today it's probably 2 minutes. But it's a journey, right? But all of us learn by pattern recognition, and it's based on your experience. So let me show you a case which I recently made a diagnosis. I used AI. So here you have, there were several cores with cancer. So this core was clearly prostate cancer. I called it prostate cancer. This core, how many of you think is prostate cancer? Ductal cancer, right? Looks like, so I called it ductal cancer. I didn't do any stains, but when I went home, this case bothered me. So I went back, I looked at the medical record. It turned out this patient had rectal bleeding, but refused an endoscopy because it was too expensive. And it was not a note that was easily found in EMR. You had to search through it. But I did do that. I found the note. I ordered the rectal cancer stains, and it turned out to be a colon cancer. So this is what I mean about human intelligence. So today we are not ready for prime time AI to replace a pathologist. But I love the tools that are available today. They can help me in my routine work. I can take away some of those manual tasks that I do routinely. I can replace them with AI. So putting this all together, what can you not do with a glass slide, right? So today you can do a lot of things that once a slide is digitized, you can share, collaborate, count, assess, quantitate, look for features. But we're getting very close to predictions. There is actually a tool today for prostate cancer which can predict which patient will need additional treatment or not. Similarly, we have tools for breast cancer. So this whole field, people call it differently. I call it imageomics, just like genomics. Right? So this will be based on image-based assays that you're going to see. At some point, they will be send-out tests. Sometimes, at some point, they will become pathologists will own these assays. So this is not my office. I only have 3 monitors, but you can think about customizing your screens, right? So if you're a GU pathologist or a breast pathologist, you can customize your screens now. You can bring all the information that you need. But AI can help assist you today. They can augment your diagnosis, or they can provide autonomous diagnosis. And this is not new to pathology, right? We did this in cytopathology many years ago. So in conclusions, we've come a long way in digital pathology and image analysis and deep learning, but the journey will continue. We have clearly demonstrated that images are of diagnostic quality, We can share images, we can use it for frozens, we can use this routinely, and improve the quality of our diagnosis. What I love about it is we are connected together if we embrace these tools and learn more about these tools. But this will continue to grow. We are in the very early stages of using AI routinely in pathology. But I think from what Dr. Connelly started many, many years ago, we have continued to build on that foundation. We have clearly using this data in a very powerful way to make an impact on patients' diagnosis. So we can deliver the right diagnosis for the right patient at the right time. So with this, I'm going to stop. I know I went a little bit over, but I'm thankful to be here and not in Cleveland at the wedding. But I don't want to miss my flight tomorrow because that's an important flight for me to be at the game. But I'm really grateful to be here and delivering the annual Connelly lecture to you. So thank you so much.
Thank you very much, Dr. Parwani. We don't have a lot of time. We will try. So,
fantastic talk, Dr. Parwani. Thank you so much for coming here, being with us, and sharing your experience. I just have a quick question. You briefly touched upon it, but do you envision a future, maybe not near future, but probably distant future, when pathology does not have to deal with a tissue lab at all? Like, we don't need processors, we don't need embedding, nothing. So we just get the tissue and we scan the tissue and we can immediately send it to AI or make a diagnosis.
Yeah, so today we can generate an image directly from the tissue. So I can create an H&E image directly from a tissue. Those technologies are already here today, but they're not in routine use and they're not of high throughput. So it'll take some time, but the technology is already here. Actually, there is a prototype that you can buy today where you can put a core of a prostate and get an H&E image within 1 minute without making any glass slides or staining or digitizing. But it'll take some time. So all of us are in different journeys. I know that different institutions have implemented digital pathology, but there will come a time where everybody will start to catch up. And who knows, some pathologists may still want to use their microscope and continue to use microscopes. So I'm not here to say, throw your microscopes and sell it on eBay. I'm saying, as pathologists, there are many different tools available for us today. Thank you.
Anil, a wonderful lecture. Thank you for giving to us all. We have research programs on in the department with spatial omics and whatever, and I have always felt, sort of using the Netflix analogy, you start by getting mailed things. Now it's in your home, the TV, in 20 seconds. I think that in the future, as the price comes down, the efficiency comes down, or whatever, that will be another tool for pathologists, because it will help the clinicians relative to therapeutics that are coming on board. And there's so much information there, with lymphocytes and all these accessory cells. I think it will really be another, log jump for the importance of pathologists and why pathologists will never go away.
Yeah, I totally agree. We just installed a machine to look at tumor microenvironment, and we are creating clinical assays around that. So it's clearly coming, not in the not so near future.
Yeah, so I just want to echo what a great talk that was. First, a quick comment. In case you miss your flight tomorrow, the Gophers have a game, right? And I'm sure you enjoy that, probably more than the one you're going for. But that's we shouldn't go into that. Can you just share your experience about your current clinical workflow where you scan your slides and pathologists are all over the place reporting. We have that as one of our limitations now is storage. So we have to decide what to scan, how long to keep them. So when you scan your cases, how long are you able to keep them on the server? And how have you managed that storage with such a very large practice you have?
Yeah, so the storage is expensive, so we still have to keep it for 10 years, right? So by CAP standards, digital images have not replaced glass slides. So if you get inspected by CAP, CMS, you're required to keep your images for 10 years. So, but as an academic institutes, we are planning to keep them forever because we are using them for research and building algorithms and so on. But currently there are no guidelines on how long you should. Some private practices are deleting them after a month once they sign them out because you still have the glass slides. Yeah, no, I think more clarity will come on these regulations. So I know we have many more questions. I'm going to stick around. I know we have a reception. And so I'm going to stop, but I will hang out and have conversations with all of you. So thank you so much. I appreciate being invited here and I'd like to. Thank you.
So please don't forget, tomorrow morning we are supposed to meet here again. There will be continental breakfast starting at about 7:15. Talks tomorrow will start at 8 for the MSP part of the symposium. Thank you. Have a nice evening.